My name is Mike from Rescue Academy, and today I'm covering the Nancy Caroline, this big textbook here, chapter 17. It's going to be respiratory emergencies. This was a big topic that a lot of people have asked me to cover. I did announce a little while back, sorry it's taken a little long for me, but a lot of people have been asking me to cover different chapters. And this is one of the most important chapters inside the paramedic textbook for those of you who are EMTs or are looking to become a first responder, please like, subscribe, do all that good stuff because I cover a lot of that content and I want to help you pass the National Registry on the first try. That is the goal. So today, again, we're going to be covering this chapter 17. Let's jump into it. Like any other chapter, I am going to be discussing anatomy. I'm going to be discussing some of the airway management, which I did cover chapter 16, if you want to go and check that video from before. And now I'm going to be covering some of the diseases that you will see in respiratory emergencies and how to treat them, different testing strategies that will help you pass that national registry. And if you have any exams in school, hopefully this will help as well. One thing I do want to say and point out is that not everybody can learn by just reading a book. Okay. Use this as a tool for if you're an auditory learner. Like for me, for example, I'm an auditory learner. If I'm learning something, it's a lot, I can retain it if I just hear somebody talk about it. So use this not to just sit down and take notes. For some of you, yes, make sure you're taking notes. But for some of you, you could just listen to this while you're in the car, while you're walking, while you're exercising, doing whatever you want. Uh, Having this playing in the background helps you remember and recall some of the information that I am discussing in today's lecture. So again, I hope this helps. If you have any questions, please comment down below. I will do my best to get back to you. All right, let's jump into this. We're starting with the anatomy. Okay, so it says the primary structures of course, we're talking about the pulmonary system, is this inverted tree, your bronchioles, right? The trachea is that top or that base of the tree that we see up there in the top left-hand corner, and understand that it branches out into smaller and smaller and smaller bronchioles, right? So it does look like a tree. I agree to that. As for the tips of the trees where the leaves would be, that is where alveoli is. Alveoli is where gas exchange occurs and allows for oxygen to hop on to those alveoli to circulate through the bloodstream and allows carbon dioxide to basically hop out and allows you to exhale carbon dioxide. Okay, I'll move myself over a little bit here so you can see this carina. It says the tracheobronchial tree actually travels that oxygen or air into the lungs. It's 4 to 5 inches. Okay, and the carina is where it actually splits into each lung. Okay, and right here in this photo, I actually like this photo a lot because you can see that the left mainstem bronchi has more of a turn. It even says it here. It says where the tracheal cartilage bifurcates, the right mainstem bronchus has less acute angle. Okay. This is important to understand. Why? Because when we talked about airway management, we said that if you intubate somebody too far, you'll cause a right main stem intubation. This is for most patients. If you intubate too far, it'll go into the right main stem. Not for everybody. Understand there is a small population where it's the opposite. Okay. But for most people, yes, the carina looks like what you see in this photo. So pretty interesting. Something I would definitely make note of or remember. The carina is where the brachial or the right and main stem bronchus change direction. Okay, at that carina. What we talked about with the upside down tree, we have larger branches that go into smaller branches and then to the leaves, right? So looking at the main stem bronchi, remember at the carina, it splits into two main stems, which those are large like tree branches that come off of your lungs, carries a lot of air. Then it goes into tertiary bronchi. Then it goes into subsegmental bronchi. Then it goes into the bronchioles, which is a lot finer, right, into the alveoli. As for dead space, the only thing I want you to remember in dead space is this is air that's inside your lungs that does not participate in gas exchange. Okay. Dead space does not participate in gas exchange. Talking about the gas exchange, where's that occurring? We said it occurs in the alveoli, and that alveoli is in the bronchioles, right? It's that very fine tubes. One thing that I want you to know about alveoli, and I really like these photos, is that it's interlaced with capillary veins. Okay. Why is capillary veins so important? Because remember, blood flows through veins, right? And this blood flow makes its way back into the pulmonary circulation, basically wraps around these alveoli. And this is where the gas exchange occurs through something called diffusion, right? With diffusion, we have this concentration of oxygen that whenever I inhale, it goes into my lungs. Those blood vessels are basically getting soaked with that oxygen. And when I exhale, I'm able to breathe out carbon dioxide through this process of diffusion. And it cannot occur if I didn't have these capillaries that are wrapped around my alveoli. Okay. So I'm able to get rid of waste of carbon dioxide. And every time I breathe in and bring in oxygen, that transfer system occurs inside the alveoli. Now, an issue that can occur with these bronchioles is a decrease in cilia. So I see here on the slide, it talks about cilia, and it's kind of like a weird place to place this term. But cilia is like these really small hairs that allows for cleaning the airway. Okay. Have you ever been sick and you've had a cough and it's a productive cough? So you're like, coughing up sputum? Well, the only way that you can do that is because you have cilia that's working to clear your airway. Whenever there's mucus production that gets built up inside your lungs, these little hairs start pushing this sputum up and out of your airway. You're able to cough and expel that mucus. So if you talk about like, let's say somebody who's chronic smoker who's been smoking for years and years and years, they destroy the cilia that's throughout their airway. And what do they have? What are they left with? They're left with something called a smoker's cough, where they have a really difficult time getting that mucus outside of the airway, and their lungs are always kind of like irritated. But yeah, lack of cilia can cause some problems with those bronchioles, and so that's just some random thing that they put here in the anatomy. We talked about protecting mucus, uh, not shielded by smooth muscle or rigid structures. Okay, it's just still talking about the bronchioles. It says smooth muscles around the airway can cause bronchoconstriction. Okay, let's talk about smooth muscle. Knowing that your bronchioles are um, basically outlined by smooth muscle, that just tells you that this muscle you have no control of, right? I know you can flex your arms, you can flex your legs, and you can flex different muscles throughout your body, but there are some muscles in your body that you just have no control of, and those are called smooth muscles. Okay, smooth muscle inside your lungs can actually cause those bronchioles to constrict and to dilate or relax, right? We don't have any control of it. It kind of occurs dependent on stressors and other things that could cause this reaction. For example, anaphylaxis. For example, asthma. Right now, it says bronchodilator medications have little effect below subsegmental levels. So bronchodilator medications typically occur in larger bronchioles, right? Allow for a lot more air exchange in those bronchioles, less in the smaller tubes. Saying here now in the tracheobronchial tree in the alveoli, branches 16 to 24 different terminal airways. So those are all the little small branches that are coming out. Entire surface is covered with those capillaries, which we talked about, where the gas exchange occurs. The mediastinum. Mediastinum is the middle part of your chest. Really important area to understand because that mediastinum has a lot of very important structures that are involved in anatomy. Heart, large blood vessels, and those large blood vessels are really important. They're called the aorta, and they are called your vena cava. Remember, we have a superior and inferior vena cava, and that brings all that blood flow either to or from the heart and it's very important. So if you have any pressure or anything that starts to occur inside the mediastinum, you can cause a lot of issues with perfusion. We're going to get to that later. Pulmonary blood flow. Pulmonary blood flow is an interesting one. Why? Because if there's a disruption in in pulmonary blood flow, it will cause some problems, not just to the lungs, but also to the heart, right? It says from the heart to the lungs via the pulmonary artery, which is an interesting conversation in itself because we all know that deoxygenated blood within the body flows through veins, except here, okay? It goes from the heart, from the right ventricle, into that pulmonary artery, into the lungs, to get oxygenated, right? That's how blood flow works. If it's been a while since you've looked at blood flow through the heart and through the pulmonary system, I highly recommend you look that up because that helps you um, understand some problems that we're about to talk about with respiratory emergencies. It says artery branches into smaller vessels, and we know through a law that we're going to talk about today that the smaller the blood vessel, the increase in pressure that there will be. Okay, it says more gas exchange between the lung and bases and circulatory system. And it says pulmonary capillaries are narrow, and narrow blood vessels can have some problems, can cause some issues, right? The first issue here that gets brought up is polycythemia. For those of you who are taking notes, please write this term down. Polycythemia means excess or too much red blood cells. Okay, too much red blood cells. Now, I think we all understand what red blood cells do, what they carry. Red blood cells carry oxygen, okay, hemoglobin, right? That's the reason why your blood is red because all the hemoglobin that's bound to oxygen, right? And when you have too much hemoglobin, too many red blood cells, your blood actually becomes really thick. The viscosity becomes thick. Think of syrup, like maple syrup. Your blood gets thick like maple syrup with polycythemia. And why is that an issue? Because when you have smaller and smaller blood vessels, remember there's an increase in pressure to push that blood flow through. And now you're changing the viscosity of the fluid, thus making it harder to get that fluid through those blood vessels. Polycythemia can cause pulmonary hypertension, okay? An increase in pressure inside the pulmonary blood vessels within the lungs. It's a problem, okay? Why is that a problem? Because it can cause a disease process called cor pulmonale. So, for those of you who are, again, taking notes, write down cor pulmonale because cor pulmonale, this term right here to my left, it is right sided heart failure due to COPD. Okay. Patients that have COPD, and I know this is a little bit premature because we're going to be talking a lot about COPD today, but COPD has polycythemia. Okay, these patients they have an issue with um, oxygenation, and because they have an issue with oxygenation, their body creates more red blood cells, thus causing polycythemia, thus increasing pressure. Cor pulmonale again is pulmonary hypertension, and the problem with pulmonary hypertension is it will cause heart failure. What kind of heart failure? It'll cause right-sided heart failure. So if I was writing notes, I would write cor pulmonale equals right-sided heart failure due to COPD. And again, like I said, we're going to be talking a little bit about COPD later in this lecture once I start getting into the disease processes. Hope this is helping so far. Perfusion. Why is perfusion such a big deal? It's a circulatory component of the respiratory system. We all know how oxygen gets around your body, and that is through blood flow. Okay, so perfusion matters. You have a patient that has poor perfusion. We call that what? Shock. If your patient's in shock, they're going to have poor perfusion. And if they have poor perfusion, then they're not going to be pushing around oxygenated blood. And that's an issue because why? Our vital organs require oxygen. Hence why when you have a patient that is in shock, if we start to lose mentation to that patient, All that's telling me is that their perfusion is so bad that it's not getting oxygen to the brain. And when the brain doesn't get oxygen, your patient becomes confused. Pretty important concept to understand. Let's move on. Cardiovascular regulation. It says the lungs are closely linked to cardiac function. The pulmonary system must work in conjunction with the cardiac system, right? Again, it carries blood, and that blood carries oxygen. And if you know how blood flow works through the heart, you'll know how it's intertwined with pulmonary circulation. Okay. Look what it says here. It says left sided heart failure progresses faster than right sided heart failure. Those of you note takers, write this down. Left side always fails before right. Left side fails before right. Something great to note. Have you ever been at the grocery store and you see that person that's standing in front of you with the really big ankles? Yeah, I've seen her too. We know exactly who we're talking about. That person has right sided heart failure. Okay. Now, the problem with right sided heart failure is typically somebody with right sided heart failure, they just have a backup in fluids that goes throughout systemic circulation. But to get to that point, they usually have gone through some sort of respiratory compromise. And the respiratory compromise with heart failure occurs on the left side of the heart. Remember, the left side is the high pressure side. And when you have a backup in blood flow from the left side of the heart, it backs up into the lungs. If you have a backup in blood flow from the right side, it goes into systemic circulation. Don't forget that. Right side of the heart backup, systemic circulation. Left side of the heart, back into the lungs, shortness of breath. It says mild hypoxia increases heart rate. Absolutely. And it says severe hypoxia will cause bradycardia. Severe hypoxia will cause bradycardia. Remember, hypoxia is the number one cause for bradycardia in children. Absolutely. Of course, it said there uncorrected hypoxia will lead to a cardiac dysrhythmia and even death. So be mindful of that. It says um, health failure. It means heart failure causes caused by changes in fluid balance, right-sided heart pumping pressure, right? We talked a little bit about these pressures. The right side of the heart's more of the low pressure versus the left side. Left side of your heart pumps all that oxygenated blood in throughout circulation. So it goes into the aorta and out, disperses it out through the body. The right side of your heart is really important because it collects deoxygenated blood, right? So if I have failures on either side, there's going to be um, issues after that side starts to fail, right? Because remember, your blood does not stop moving. Even if your heart starts to fail, it just keeps going, right? And there's some issues that your patient's going to experience if their heart can't keep up with the blood flow. Let's take a look here. We got mechanisms now of respiratory control. And I actually like this photo, and I'm going to help you understand what happens with your diaphragm every single time you inhale. Because some test questions get a little bit weird on how they word things. It states here that the body takes in air by negative pressure. Always remember that. You have a negative pressure within your chest that makes it easy to draw air in. Can you imagine if you had to work really hard to get air in? You would be tired all the time. But because there's a negative pressure inside your chest cavity, inhaling is super easy. Thank God, right? Now let's talk about what happens with your diaphragm. Take a deep breath right now. What happened to your chest? Your chest wall expanded, right? It got larger. So what does that mean about your lungs? Your lungs got bigger. For your lungs to get bigger, your diaphragm has to get out of the way. Remember what I'm saying here. For my lungs to expand, my diaphragm has to get out of the way. So where's your diaphragm going to go? It's going to go down towards your abdomen. Now, do a big exhale. Once you get rid of all that air, what happens to your chest wall? It goes back into like a neutral position, or it decreases in size. So what's happening to your lungs? Your lungs get smaller and smaller and smaller. Well, if my lungs are getting smaller and there's less room for my lungs and my chest cavity, what's happening to my diaphragm? My diaphragm is rising up into my chest. So remember, take deep breath. Your lungs get bigger. Your diaphragm goes in a downward position. When you exhale, your lungs get smaller and your diaphragm rises. Like I said, there's some weird test questions out there talking about what the diaphragm's doing whenever you inhale and exhale. I hope that helped. All right, so let's go ahead and talk here now about hypoventilation. Now, I know I've hit hypoventilation so much in chapter 16, and I hope that helped. But talking about some respiratory emergencies, it's a big deal when we talk about hypoventilation. Remember, when I said hypoventilation, it just means that breathing is inadequate, right? Hypoventilating means shallow respirations, and shallow respirations can cause some big issues with your patient. Let's go ahead and see what it says here. It says carbon dioxide accumulates in the blood when the lungs are failing, right? Combines with water to form bicarbonate ions and hydrogen ions known as carbonic acid. Okay, so there's an acid buildup inside your blood will result in acidosis, impaired ventilation caused by a variety of factors. I'm going to go ahead and move myself over so we can look at some of these factors because they're important to know. Okay. First one it talks about is upper airway obstruction. We know this can be choking, right? Maybe it's your tongue is swelling and it's not allowing you to breathe adequately. Well, if you can't breathe adequately, understand that you will become hypoxic and you will die from hypoventilation. Okay. Let's start with that. So if hypoventilation is not corrected, your patient will die. Next one, lower airway obstruction can occur from trauma, obstructive diseases such as asthma or COPD, an increase in mucus production, okay, also potentially COPD or asthma, and also says airway swelling known as edema, which we're going to be talking a lot about those. Absolutely. If we can't fix those, your patient will start to hypoventilate and your patient could go into cardiac arrest. Chest wall impairment. Your patient's unable to take deep breaths because, let's say, pain, right? Pain from a flailed segment, maybe broken ribs. And every single time the patient has something called pleuritic chest pain, for those of you note takers, pleuritic chest pain is pain on inspiration. Oh, it hurts whenever I take a deep breath, right? A pneumothorax also has pleuritic chest pain. And these patients, they take way shallower breaths. Okay. Pleural effusion, restricted diseases such as sclerosis or even kyphosis, which is an interesting one. But it's saying that you're unable to take deep breaths because there's something else that's restricting you to do so. So what do you do as a patient? You take more shallow breaths. And again, if you're breathing shallow for long enough and it does not get corrected, your patient will die. Neuromuscular impairment, such as overdose, Lou Gehrig's disease, also known as ALS, and even carbon dioxide narcosis, can all lead to hypoventilations. Okay. Hypoventilation, again, I can't stress this enough, man. If your patient is hypoventilating on a test question, all that's the only thing I need to be told in the test question is A, the term hypoventilation, B, shallow breathing, right? Uh, I am considering breathing for the patient. Okay. All these different things that we saw here that can cause hypoventilations don't mean that you need to BVM all of them. Okay. There are different treatments for each one of those patients. And if you're able to treat them before the patient begins to hypoventilate, you can fix them. We'll get into some of that. Okay. But understand that just because somebody has a pneumothorax, just because somebody has asthma, right? We have a lot of different treatments out there for these patients. But if it gets worse and it progresses and progresses, and now the patient is starting to lose mentation and they start to breathe very shallow, they're going to something called respiratory failure. And we need to ventilate for that patient. Take a look at here. It says carbon dioxide levels are directly related to what? pH, your pH system. Know this for you note takers, your normal pH is 7.35 to 7.45. That's normal. If it drops below 7.35, your patient is acidotic. If your patient is acidotic because of a respiratory compromise, not good. This means that your patient is not breathing adequately. Let me repeat that. If you have a pH balance less than 7.35 because of a respiratory problem, this means that your patient is not breathing adequately, they are hypoventilating, and when you have a drop in pH, what's happening actually to your end-tidal capnography? It's going high. I know it sounds confusing, but write this down on your notes. If I have a low pH, so pH less than 7.35, and it's respiratory related, I'm going to have a high end-tidal capnography. Okay. This helps me out a lot as a paramedic. Why? Because I check end-tidals often, right? I put my patient on end-tidal capnography. I see an end-tidal capnography of 52, and my patient is having shortness of breath. What is that telling me? That my patient is hypoventilating. I need to consider BVMing or assisting ventilations for this patient. Okay. Some a lot more causes over here. We did discuss a lot of those causes already. Um, Atelectasis, for those of you who are taking notes, there are buzzwords that I would always recommend writing notes on. So if you've never wrote a note on atelectasis, all it means is like collapsing of the alveoli. And whenever you have a collapsed alveoli, there's a problem with gas exchange, right? So even if this patient is breathing adequately, but they have atelectasis, the patient is um, not transferring gas or not exchanging gas like they're supposed to. So your patient's going to have a low SpO2, right? Even though they might have a good respiratory rate. So something to consider. And yeah, we're going to talk pneumonia a little bit. Okay, we already talked about a lot of these that can cause hypoventilation, conditions that impair neuromuscular apparatus. It says head trauma, ICP, brain tumors, a lot of different things. Hyperventilation, somebody who's breathing too fast, right? People breathe in excess from increasing rate or depth of their respiration. Okay, releases more carbon dioxide than normal. So remember, every single time I exhale, I breathe out, I'm getting rid of carbon dioxide. Now, one thing that I want you to understand about carbon dioxide is actually how me and you know when to breathe, right? We don't have to think about it, right? I can go to sleep right now where my brain shuts off and I continue to breathe. And how does that happen? Because there's carbon dioxide has to stay within a certain range for me to continue breathing, right? As my carbon dioxide starts to rise, remember, normal carbon dioxide, 35 to 45 for you note takers, 35 to 45 is considered normal carbon dioxide. As my carbon dioxide starts to rise and gets higher and higher, I have the urge to breathe, right? Have you ever been in a pool where you held your breath underwater and you start to get anxious and your body once it starts to crave breathing? Well, what's happening is your carbon dioxide is stacking, right? It's getting higher and higher and higher, and it's basically forcing you to take a deep breath. So understand that when I breathe too fast, what's happening to all that carbon dioxide? I'm getting rid of it. You're getting rid of all your carbon dioxide, and you need that carbon dioxide to get you to breathe. So let's take a look. It says it releases more carbon dioxide than normal, resulting in alkalosis. Shocker, right? So if I said high carbon dioxides caused what kind of pH problem? Low pH, which is called acidosis. It's now the opposite. Too fast of breathing blows off too much carbon dioxide, thus causing my carbon dioxide to be low levels, less than 35, and my patient is considered alkalotic, which means they have a high pH. I know it sounds confusing, especially the first time that you might have heard this, but I hope you're taking notes, and I hope some of this is making sense to you. It says some of this is triggered by emotional distress or panic. Absolutely. Hysterical hypervention or hyperventilation syndrome is typically occurring when your patient is suffering from anxiety, right? How are you going to find this on your patient? And I'm going to show you, I'm going to paint you the perfect picture of a patient. You have somebody who's tachypnic. Let's say that they're breathing 30 times a minute. They appear anxious, but they look like they're short of breath, right? Put them on your stretcher, start hooking them up to the monitor. First thing that we note is an SpO2 of like 99 to 100%. Great SpO2. You listen to lung sounds, clear and equal bilaterally. So we got clear lung sounds. I got an SpO2 of 100. We throw on capnography and it's less than 35. Okay. I'm expecting tachycardia. I'm even expecting higher blood pressure, right? This patient's worked up. This is hyperventilation syndrome. How do we treat patients like this? Help them relax, chill, right? Maybe we can verbally talk to this patient, try to coach them down, have a conversation with them, try to get them off of what's causing this trigger, right? Or this anxiety attack. Maybe it was a car accident. A lot of different things can cause people to have this problem. I believe I did talk about this in the last chapter. Remember, your patient will have something called carpopedal spasms, where their hands will get tight, right? Tingly fingertips. Let's see here. Of course, next slide, right? It says causes numbness to the hands, feet, and mouth. Ultimately, will lead to carpopedal spasms. Having patients rebreathe carbon dioxide can be dangerous. Hence, why you're never going to see like professionals or something that's inside like a textbook ever talk about the brown paper bag. Way back in the days, they used to tell you people to rebreathe their own CO2 to kind of level out their CO2 levels. Because remember, they're blowing off CO2, and if they're doing it in excess, then they're not going to have enough CO2 within their own bloodstream. So they say if you blow it off into a paper bag, you're rebreathing it, starting to allow your CO2 in your bloodstream to rise. It's dangerous. Okay. It's very hard to monitor. So you can cause some serious problems. Instead, just put an armor breather mask on that patient. Okay. Put an armor breather mask on that patient. Don't worry, it has ventilations or vents on the sides of the armor breather mask where it allows it to ventilate. And that patient is still able to rebreathe some of that CO2. It says hyperventilation may cause the body's attempt to raise pH levels. Okay. You can see this in Kussmaul respiration, sepsis, or even shock. It says in high or extreme measures, how can we treat it? We can also use sedation. I recommend, right? Your patient is really worked up and they're blowing off a lot of CO2. Give them a little bit of sedation. I'm not telling you to snow this patient. I'm not telling you to give 5 milligrams of Versed or something like that, but give them a milligram, all right? Help them relax. Even you can even use Benadryl, okay? Help this patient relax. Some of these other things, breathe with the patient, have the patient count to 2 in between each breath. It's a good trick. Distracting techniques. It's my favorite personally. Okay. If the patient sing a song, I'd rather not do that. Okay. It's a weird one. I'm going to sing. No, I probably won't. That'd be even weirder. All right. Let's talk about respiratory assessment. It says thorough assessment. Many respiratory ailments are life threatening. Okay. Talking about a respiratory assessment, the first thing that comes to my mind is a focus exam. Now, one thing I want you to get really good at, this is for you paramedic students that are inside like labs and doing assessments, is getting a very good focus exam depending on what your patient's presenting with. For example, we have a patient who is, you're en route to a patient who's, we'll say 62 years old with respiratory distress. Okay. Obviously, you do your intro, BSIC safety, number and location of patients. You consider your additional resources, considering this possibly an NOI, right? You walk up, and when you ask for your general impression, they say your patient is tachypnic, right? Short of breath. You see your patients in a tripod position, right? They start using these words that pointing me into the direction that this patient's in respiratory distress. I need to perform a focus exam. Now, I understand you're going to start with a primary exam, right? You're going to say, okay, I want to determine what are my ABCs. What's my patient's LOC, right? Before I start diving more into an exam of this patient. But what I want you to start with is not just airway and breathing, my rate, rhythm, and quality of breaths, but I also want you to get a quick SpO2, end-tidal capnography, and lung sounds. Let me repeat those. Rate, rhythm, and quality of breath sounds. Sorry, rate, rhythm, and quality of breathing, lung sounds, SpO2, and capnography for focus exams. Okay. This is going to help me with my respiratory assessment to determine which route I'm going to go for my treatment. Saves you a lot of time. I think we're I think we all agree that there are certain things that are out there that can cause respiratory distress. It's not just asthma, right? If you have excess chlorine in the air or other chemicals, they'll cause shortness of breath. Do I want to be in an area where there's fluorine in the air that's causing my patient shortness of breath? Absolutely not, right? So make sure you're taking your scene safety as a top priority. If you have a lot of patients in that area that are all short of breath, either put on an SCBA of some sort or let's get those patients out of that area into a more controlled environment. Okay. I'm going to move through some of this stuff. Okay. PND. PND is a really good one. For you note takers, PND is called paroxysmal nocturnal dyspnea. Sudden, I love the word. Okay. For those of you taking notes, test questions, love this, right? The term sudden or acute shortness of breath that occurs in the middle of the night. Okay. Why do you think that happens in the middle of the night when you're laying down? Right? People with PND that have shortness of breath in the middle of the night that comes on all of a sudden, it's because of fluid buildup, typically seen in left-sided heart failure. And when they lay down, it feels like they're drowning. So they wake up startled, sweaty, short of breath, difficulty breathing. And guess how these patients have to sleep from now on? In a recliner. Okay. So be mindful, man. Whenever you see a test question, they use terms like sudden or acute shortness of breath, or they say something that's going on in the middle of the night. PND, right? Left side of heart failure. CHF. Says the ability to move air can be hindered by different factors. Yep, we're all aware of those. We're going to get into emphysema and chronic bronchitis. Just talking about how they present. I'll talk a little bit about that later. Okay. Here's a good one. There's our positioning, right? We got different types of positioning here being discussed. This one that we can see is tripoding, right? Typically, if you see somebody in a tripod position, this is telling me as a provider this person's in respiratory distress. But I like respiratory distress when we talk about airway problems, right? I want to see and I want to treat a patient who's in respiratory distress. I don't want to treat, I can't say that. I prefer because it's better for my patient if they're in respiratory distress. If they are in respiratory failure, this is going to require me to do a lot more work, right? I'm now going to be ventilating the patient and even upgrading their airway with an advanced airway. Well, let's take a look at some of these other uh, positions. Lying flat may indicate a sudden deterioration. If your patient is laying flat, or your patient is head bobbing, okay, head bobbing just means that your patient's doing these while they're talking to you. Okay. It's usually signifying that the patient is having a lack of blood flow to their brain and the patient is starting to become altered. It's an ominous sign because it's showing that your patient is going into what's known as respiratory failure and you need to assist ventilations. If your patient does have a CPAP at any point on their face while there's head bobbing occurring, take the CPAP off. That patient needs to be ventilated. Uh, just real quick on this one, it talks about breathing alterations. Mm, skipping that. Increased work of breathing in your primary survey, right? We look at this little kid. What you're looking at there is called substernal retractions, right? And you can see underneath his chest wall where that looks like sunken in. That's a substernal retraction. It's a use of accessory muscles. The problem with that is that this kid has to use additional muscles that he's not used to using, thus going to cause an even more increase in shortness of breath. Because remember, muscles to allow muscles to work, they need oxygen, right? So now these muscles are utilizing oxygen, and it's going to make this kid deteriorate even faster. A lot of different signs and symptoms here of increased work of breathing. We talked about those retractions up there on the top. If at any point you want to stop this video and just read through these, not a terrible idea. I'm just going to talk about them really quickly. Nasal flaring shows that the nostrils are literally flaring, typically seen in somebody with shortness of breath. A lot of the times, this is seen in young kids. Okay. Tracheal tugging says during inhalation, the thyroid cartilage is drawn upward in the area just above the sternal notch. Um, called tracheal tugging. It's when they're really struggling to breathe in. Paradoxical respiratory movement. During inhalation, the epigastrium is pulled in as the abdomen is pushed out, creating a seesaw effect. Okay. Paradoxical respiratory movement. Pulsus paradoxus. Pulsus paradoxus is something that is commonly seen on the national, right? Commonly seen in exams. Pulsus paradoxus is typically in your patients that have obstructive shock. Okay. Obstructive shock, we talk about tension pneumothorax. We talk about tamponade, right? So if your patient has a pericardial tamponade and during inhalation, they breathe in, their blood pressure drops at least 10 millimeters of mercury. This is considered pulsus paradoxus. Definitely a good thing to know for those of you who are taking notes. Pursed lip breathing, something that is commonly seen in our COPD patients. Okay, pursed lips. So it just means that their lips are like this. They're doing that to increase pressure. Okay, they're basically creating their own CPAP. Grunting. Grunting is something that is commonly seen in small children because their airways are so small. And whenever there's excess swelling that occurs in the upper airway, it causes like a grunt type sound. Often, when you read test questions and they use the term stridor, you're thinking like this high pitched squealing sound. It's not always the case. Sometimes it's a grunt.
So, an interesting thing about this slide in particular is it talks about breath sounds in a primary survey. Why is that interesting? Because typically, breath sounds are not found in the primary survey. Okay, they're usually in a secondary survey, but why would they be here? Because your patients are short of breath, plain and simple, right? We call this a focus exam. When your patient has shortness of breath, there's a focus exam that needs to be done early. Okay. And I always like to say that there's four things included in that. We got respiratory rate, rhythm, and quality. I got lung sounds, SpO2, and end-tidal capnography. As somebody who teaches paramedic, I'm telling you now, I very, very rarely see any test questions on these normal breath sounds. Okay, so take that what you want. If you want to make notes on it, go for it. Honestly, I rarely ever see any test questions on this, rightfully so. Adventitious breath sounds, understand that the word adventitious just means abnormal. Okay, so when we talk about abnormal lung sounds, we talk about wheezing, crackles, bronchi, right? Remember, the word crackles is also in line with rails. So if you ever see rails on a test question, understand they're talking about fluid. Some other abnormal breath sounds here. We got stridor, grunting, and death rattle. Death rattle is like a very deep, um, kind of like a deep mucusy sound. It's usually found in patients that are right about it going to cardiac arrest. A lot of patients that are like on hospice and stuff, they start to have a death rattle when it's getting close to them to dying. Usually these patients are unresponsive when there's that. Obviously, it says the most ominous is no sounds at all. Do not think that somebody can't be conscious with no lung sounds. Okay. Please understand that if you are ever taking an exam and it says that on auscultation there is no lung sounds, it's telling you that the bronchioles are so constricted that there's no air passing. So when you listen to lung sounds and you hear absolutely nothing, it's a problem, right? Those lung sounds need, or those bronchioles need to be opened. There needs to be beta 2 agonists at play here. So be mindful of that. Your patient cannot live for very long if there is no lung sounds. Noisy breathing, snoring, gurgling, stridor. Uh, the term gurgling, I like seeing this here on this slide because the term gurgling, whenever it's used in a test question, they're trying to, they gave you a hint that you need to suction. We all know that airway management is a life threat, right? And if they say the term gurgling in the test question, make sure you're picking suction and know the amount of seconds that you are suctioning. I went over that in airway management. Go check that out. Quiet breathing, it says hyperventilation, shock, acidosis. Um, yeah, remember, quiet breathing, all they're saying is that the patient's hypoventilating, okay, as seen in shock and potentially acidosis. Here we go. Some very good adjectives to know. Those of you taking notes, please, please, please know these terms. The first one is frothy pink sputum. Frothy pink sputum. Always going to be in a heart failure, preferably left-sided heart failure type test question. Um, in actuality, it's funny, man, because whenever I was a student and I would always read these test questions with pink frothy sputum, I would think, man, these patients got to be crazy. There's gonna be like foam coming out of their mouth, and in actuality, it's not like that. And if your patient does have pink frothy sputum spewing out of their mouth, that patient needs to be intubated. That patient's going into respiratory failure, and that means that they are so full with fluid that it's coming out of their mouth. Typically, whenever I see pink frothy sputum in actual real life on calls, is after post intubation. So we'll intubate some of these patients, and then once we start bagging them, and that some of that fluid comes up into the tube. So we do see that. Thick dehydration or antihistamine use. Interesting, right? The term purulent. Purulent I see very commonly in questions. Purulent is an infection. Okay, so purulent sputum, also known as pus, typically kind of like a white color. It's just telling you that this patient has an infection. So whenever I see purulent sputum, I'm thinking pneumonia, I'm thinking sepsis, right? I'm thinking the patient's going to have a fever. So know that term, purulent. Yellow, green, or brown also tells you that this patient possibly was suffering from an infection. It says an older secretion, okay? Decomposition of an infection. Clear or white, seen in bronchitis, and then blood streaked, TB, tuberculosis, pulmonary edema, trauma from coughing, right? Could be hemoptysis, could mean that the patient has lung cancer. There's multiple things that could have blood inside sputum. But great table here. I would definitely know those. Some abnormal breathing patterns. Whenever I hear the term abnormal breathing pattern, understand that breathing, they call them an IE ratio, inspiratory to expiratory ratio, which should be 1 to 2, right? That's normal IE ratio. Whenever I inhale, my exhale should be twice as long. That's a normal breathe. If it is longer on my exhale, maybe like a 1 to 4, that's considered delayed exhalation. That's seen in wheezing. Okay. When I have crackles or rails, I usually have about a 1 to 1 IE ratio. Abnormal, right? but it kind of helps me to know ratios when I do my in-tidal capnography and I can see waveform. Makes my life a lot easier to kind of dictate what's going on with my patient's breathing. Let's take a look at some of these irregular respiratory patterns. It says most respiratory centers are in and around the brainstem, which is so true. Remember, your brainstem, it controls your automatic vital signs. So, like your respiratory rate, maybe your blood pressure, heart rate, things of that sort. So, when we look at the first one, it says apneustic breathing. Apneustic breathing is just the opposite, right? So typically I'll have a short inspiratory phase and a longer expiratory phase. It's flopped. So you have a longer inspiratory phase and a very short expiratory phase. Okay, abnormal. Biots and Shane Stokes are found in typically ICP. So that's like head trauma. Could be hemorrhagic strokes, but these patients have an increased pressure with inside their cranial vault. Biot's respirations, the best way I can always explain this is that is the VFib of respiratory patterns. For those of you who know cardiology, VFib is like this, like when your heart quivers and it's just all over the place. Same thing with biots. So they're breathing fast, slow, not breathing at all, then it's all over the place. There's no pattern to it. It's just all over the place. It's also known as ataxic respirations. And biots, same thing. Shane Stokes respirations is an actual breathing pattern. I actually have a pretty good video of somebody with Shane Stokes breathing on this channel, so go check that out. But it's a breathing pattern where the patient breathes fast, slow, apneic. They start ramping up again, slow, apneic. And they just do this breathing pattern that goes from apnea to fast to slow. And it stays in that pattern. Okay. Completely different than biots, but both from ICP. I always like this little chart. So it kind of shows you in waveforms, kind of like an EKG on what they look like. Again, biots respirations, which you see right there, completely irregular. It's all over the place. Yeah, and you can see the different patterns here. Always in our primary survey, we need to assess circulation. We know that. And why is that important for breathing and respiratory emergencies? What's going on with this little kid's feet? We call this acrocyanosis. Okay, this little child, which is not abnormal in childbirth, but acrocyanosis is telling me that there's poor perfusion to the extremities, right? So we get some of that shunting where your core is pink or normal colored, normal toned, because all your vital organs are getting perfused adequately, yet your peripheral extremities are blue or cyanotic, right? So that is something I want to note. Also, mucous membranes around the mouth, something important to check. We can see if their tongue is white. That might indicate that the patient is dehydrated. I'll be honest with you, I don't think I've ever seen a paramedic test question that talks about what is a healthy hemoglobin level. 12 to 14. Okay. Um, just understand what cyanosis is means hypoxia, right? Whenever they use the term cyanosis in a test question, we know we have to give this patient oxygen or we have to maintain an airway the best way that we can. Dark brown skin says high levels of meth hemoglobin. Okay. Uh, it's funny because that talks more like methemoglobinemia, like dark blood, typically a sign of a toxicity from amyl nitrate. We'll discuss that in toxicology. That's more medical. Pallor, something very important to know. That term pallor there talks about poor perfusion. Okay, when someone's pale, typically seen in shock. So dry, uh, cracked lips, sunken eyes, all these things are for dehydration. Remember, another key sign when you see different signs of dehydration, always perform a orthostatic hypotensive test. Have the patient stand up, sit down, reassess blood pressure and heart rate. If you've never done an orthostatic hypotension test, just remember that whenever that patient stands up from a seated position, if their blood pressure drops and their heart rate increases more than 20, blood pressure drops more than 10, that is considered a positive orthostatic hypotensive test, and that is a sign of dehydration. Your patient needs an IV and they need fluids. Transport decisions, we're pretty good on all that stuff. Going into history taking, uh, I'm gonna travel through some of this stuff unless I see something that's like really stands out that I think you need to know as a student. Um, Obviously, we need to investigate their chief complaint. Hey, do you have asthma? Do you have COPD? Were you traveling recently? Have you been coughing? All these things are obviously very important, but I feel like if you're at this stage where you're learning about respiratory emergencies, you kind of already know that stuff. Get your sample. Talking about a secondary assessment, remember I said that there's certain things that I want in my primary, more of like a focus exam, just to determine how my treatment is going to be dictated, right? So I would have done a lot of that stuff pretty early. I'm not saying that a secondary assessment is not important later on. We still need to do a full check, fever, or check temperature, check the blood glucose levels. There's a lot of different things we need to check during our secondary assessment as well. One thing here, though, that I just saw, carbon dioxide may not be removed and the lungs not functioning correctly. Okay. How could we check that with a neurological response? That could be because the patient has biotch respirations or the patient might be unresponsive and has an irregular breathing pattern. So that's something we need to check uh, with our neurological exam. Is my patient there mentally? JVD. Okay. I get out of the way to see this woman's JVD. Impressive. How do we assess for JVD? 45 degrees, right? Always place our patient in a 45-degree angle. We can turn their head to the side and see if we see JVD. It just says jugular veins are engorged with blood. Rough measure of pressure within the right atrium. Now, typically, if your patient's suffering from right-sided heart failure, your patient will have JVD. There's several different causes that can apply pressure to those jugular veins. One of them being uh, tension pneumothorax or even a cardiac tamponade. Okay. Says here also COPD can be a cause of JVD. Says check for in the neck, see if the trachea is displaced. Understand tracheal deviation of any type is a late sign of a tension pneumothorax. To me, if they ever on a test question say that the patient has a tracheal deviation, it's a super easy tension pneumothorax type question. Most tension pneumothorax questions that I see do not have tracheal deviation because it's too easy of an identifier. So know all the other signs and symptoms of tension pneumo. Here it says press on the liver when the patient's respiratory and within respiratory distress and semifowlers, right? So what they're saying is you're checking for hepatomegaly, right? An enlarged liver. And when you apply pressure on that liver, you can see JVD. Feel vibrations of the chest when the patient breathes. Chest and abdominal trauma can cause respiratory distress. Absolutely. Absolutely. One, I don't know why this just came to my mind, and it's something that I think you need to know, especially if you're taking a national registry exam. Somebody can get abdominal trauma that can literally push abdominal contents into the chest wall, right? We call that a diaphragmatic herniation. So and believe it or not, some kids are even born with diaphragmatic herniation. So when the abdominal contents, aka your stomach, is pushed through the diaphragm and into the chest wall, you actually have something called a scaphoid abdominal appearance, which means your belly looks concaved. A normal belly is flat or distended. If it is concaved and you hear bowel sounds in the chest, whenever you're taking a test, if they ever say your lung sounds have bowel sounds, it's a diaphragmatic herniation due to possible abdominal trauma. That patient needs to be intubated. You need to drop an NG tube, okay, and you need to elevate the head of the bed. I would say about 30 degrees and give positive pressure ventilations. Diaphragmatic herniation. Good one to know. A couple other things here that we get to see in these photos. Okay, a couple things I need to talk about on this slide. Just looking at the photos, we see pitting edema here on the left-hand side, and we see digital clubbing. Okay, digital clubbing. We'll talk about that one first. Those are the fingertips that look like ET. Those fingertips are basically saying that this patient has prolonged hypoxia for a long time. Okay, don't think just because someone's short of breath, their fingers start to change. This is like a digital clubbing is somebody who is hypoxic and they live with hypoxia, right? Typically, these are your patients that uh, usually when someone lives with hypoxia for a long time, it's usually your COPDers, right? But this person has poor management, I would say, of oxygen. They need oxygen. On the left-hand side, we have pitting edema, and you can see it looks like somebody's thumb was indented inside that person's ankle. That is a bad sign to say that the person is retaining water, and you'll usually see that in right-sided heart failure. Now, remember what I said earlier in this lecture, left side first, so the patient was short of breath, and then it causes right-sided heart failure. So some of these patients you'll come across, they'll have this pitting edema. It's a bad sign that they're retaining a lot of water. One other term in here that is a very good one to know for testing. It's pulsus paradoxus. Pulsus paradoxus. Typically, with pulsus paradoxus, you're going to see this in obstructive shock. Your patients with tension pneumothorax and your patient with a cardiac tamponade. Pulsus paradoxus is a decrease in blood pressure of at least 10 millimeters of mercury every single time your patient inhales. So they breathe in and their blood pressure drops. But when they exhale, their blood pressure comes back up. So good luck to you trying to figure this out on the road. But if you're taking an exam and they tell you that either A, your patient's blood pressure is dropping every time they inhale, and they're asking what this term is, just know it's pulsus paradoxus, or that they tell you that the patient has pulsus paradoxus in the text question, just know it probably they have some sort of obstructive shock. Hope that helps. Okay, coming into your vital signs, some ominous signs. Remember, ominous just means like really bad. Ominous signs, bradycardia, hypotension, and falling respiratory rates. Um, More and more are my seeing test questions that don't have falling respiratory rates because I feel like those are too easy. I'm not saying you're never going to have a test question that shows your patient's respiratory rate is 6. You know, you might have those. But typically, like an ominous sign of respiratory problems, yeah, bradycardia. If your patient is becoming bradycardic, just know that they are decompensating. It's a bad sign, man. Whenever you have somebody with a ailment that's like a bad illness, could be respiratory distress, could be whatever the case, and they now you see bradycardia, it's usually a sign that that patient's probably not going to live for much longer. So just be mindful. Definitely an ominous sign. Okay. Talking about stethoscope, make sure you're using one. Pulse oximetry, not the biggest fan of pulse ox because they're not always accurate. But one thing I would say about pulse oximetry is it needs to be above 94 for your average patient. The only patient that it doesn't need to be above 94 is your COPDers, okay, which we're going to talk about a little bit later. End-tidal capnography. I like this way more than my pulse ox. So any patient that is short of breath, they get both, but I am putting a lot more trust, I guess, a lot more emphasis on my end-tidal capnography than I do with my pulse oximetry. Okay. Um, Talking about peak expiratory flow, this is per minute. Can't say I've ever seen test questions on peak expiratory flow, but it says that it can vary depending on the age, sex, and height of your patient, but normal values up to 700 liters per minute. Interesting. Mhm. All right, we're getting into the more meat and potatoes of probably why you're here, right? What do we do about these patients with shortness of breath? Okay. Kind of got through all of our assessment stuff. Talking about supportive care. Supportive care is always an important one to understand. Supportive care just means like I'm going to reassess my patient. I'm going to maintain their mentation or keep assessing this patient. Supportive care is usually a great answer on a test question, depending on the severity of the call. And I'm not saying that all calls that don't have a high significance need doesn't need supportive care, but understand that supportive care is one of those answers for certain ailments that we don't have a treatment for. Okay, we don't actually treat certain uh, either dysrhythmias or we don't treat a overdose of some kind. The answer is always going to be supportive care. Take them to the hospital, transport, rapid transport, right? Administration of supplemental oxygen, monitoring and transport is always something that we're going to do for our respiratory patients. Position of comfort, psychological support. Okay. All good stuff to think about. Says decrease the work of breathing. Muscles work harder during respiratory distress. Substantial energy is required to compensate for respiratory distress, requires more oxygen and ventilation. Patients cannot eat or drink normally, may fatigue to the point of decompensation. Very true. Okay, so your patients that are short of breath, the issue with shortness of breath is dependent on how long this person is short of breath. So if I've ever watched somebody go into cardiac arrest from a shortness of breath, it's always because they took too long to call for help. The unfortunate truth of it. To help their work of breathing and to decrease the amount of muscle use required to breathe, help the patient sit up. Okay. Patients that are in a high Fowler's or even in a tripod position have less work to do to breathe. It says remove any restrictive clothing. Do not make the patient walk. Do not make the patient walk. Relieve any gastric distension if needed. Okay. So if your test question says that you've been providing either excessive BVMing or too long or BVMing for several minutes, or your patient has a distended abdomen, you might want to relieve gastric distension via an NG or an OG tube, depending on your patient's mentation. It says do not have the patient lie on the unaffected lung. Unaffected lung. Because there are plenty of test questions that I've seen where, like, if the patient has a tension pneumo, of actually laying the patient on the affected side, um, but never lay them on the unaffected side. Administer an effective concentrations talking about oxygen. Now, one thing I do want to say about oxygen is oxygen can be given at different stages. And what do I mean by that? Obviously, the least invasive is going to be a nasal cannula, to an armor breather mask, from an armor breather mask to a CPAP, from a CPAP to a BVM, right? Understanding when to use each one actually takes some knowledge on your patient, some knowledge on how this whole treatment system works. If your patient has a good respiratory rate, rhythm, and quality, I say all those three because they're all extremely important. If they have a good respiratory rate, rhythm, and quality, we can put them on the least invasive. They could be hypoxic, sure, satting at 84%, but if they have a very good respiratory rate, rhythm, and quality, putting them on something least invasive and working my way up is not a terrible idea. But if my patient has labored breathing, that is a quality that is not good. Labored breathing, not good. I'm not going to place a patient that is labored breathing on a nasal cannula. They are going to immediately get upgraded to a non-rebreather unless something else pulls me into a different direction. For example, let's say that somebody has labored breathing, but they are wheezing. I am not going to waste time to put them on a non-rebreather when they need a nebulizer, right? Or my patient has crackles with labored breathing or shallow breathing. Be mindful when you hear these terms, you need to know, hey, what is going on with these lung sounds and can I change my direction? Maybe it's going to be CPAP depending on their mentation or BVM, okay? I hope that made sense because too often do I see EMTs that are like shortness of breath, oxygen. It's like, whoa, chill, man. What is the quality of breathing? What does the test question say? That will dictate how I treat. Or let's say you're in a lab. If I ever say that a patient has poor mentation and shallow breathing, you better be oxygenating via BVM. Okay. You should be considering to upgrade that patient's airway. Know the adjectives. Absolutely. Talking about bronchodilators, it says those without bronchospasms benefit only slightly. Okay. It says those without bronchospasms can only benefit slightly. So bronchodilators are for patients with bronchospasms. Bronchodilators ineffective in cases of pneumonia, pulmonary edema, and heart disease. Interesting. Okay, they're saying that bronchodilators do not work in these cases. Typically not used for pneumonia, typically not used for pulmonary edema or heart failure, or heart disease, rather. Remember, patients with pneumonia and heart failure, they have PE, right? Or it's hard for me to say PE. PE stands for pulmonary embolism, pulmonary edema. Okay. I do not give bronchodilators to patients with pulmonary edema. Uh, you can consider it with patients with rhonchi, uh, but understand that typically when somebody has rhonchi, they need antibiotics, right? So be mindful. Fast acting bronchodilators, it says most stimulate beta 2 receptors in the lungs. Understand that don't not all beta agonists just affect beta 2, right? They're also going to affect beta 1. And if you remember anything from cardiology, beta 1 is heart, beta 2 is lungs. And if I have a beta agonist, I'm going to increase heart rate, right? So by giving them a beta agonist, such as albuterol, remember we could give up to 5 milligrams for adults now. We are going to cause those bronchioles to dilate. And by causing bronchioles to dilate, we allow for more airflow in and out of the lungs. Ipratropium, now available in aerosol and inhalers. Ipratropium bromide is also known as Atrovent. Atrovent. So this ipratropium bromide is an anticholinergic. If that rings a bell at all, that means you probably know a little bit about cardiology medications. Your anticholinergic in cardiology is atropine, right? So we have atropine and atrovent. Quick lesson on how that works is you have something called cholinergics, and cholinergics cause a flooding of a neurotransmitter called acetylcholine. Now, when acetylcholine reaches my lungs, remember this is a neurotransmitter. When acetylcholine reaches my lungs, it causes bronchoconstriction. It makes it hard to breathe. It makes it hard to exhale. Typically, when you have a patient that has bronchoconstriction, they can breathe, bring air in, but they have a difficult time getting the air out. Hence why their IE ratio, inspiratory to expiratory ratio, is about 1 to 4. Delayed expiratory phase. It's a wheeze. Now that we got that out of the way, going back to our neurotransmitter. So whenever this acetylcholine reaches my lungs, it causes the bronchioles to constrict. Obviously, I need to get that patient a bronchodilator to open them back up. But if I give something like ipratropium bromide, which is an anticholinergic, I can stop that acetylcholine from reaching my lungs. Does that make sense? I can stop that process from occurring, thus making my bronchodilators work effectively. So we call it a cocktail, right? Cocktails when we put albuterol and Atrovent in the same nebulizer. Remember, nebulizers are flown at 6 to 8 liters per minute. There's that aerosol therapy. Um, Here it says need gas flow of at least 6 liters per minute to keep particulates an optimal size, right? So the patient can inhale it. Remember, whenever we're having a patient breathe a nebulizer, we want them to take deep breaths. We need to get that medication down deep into their lungs. That's how we get that medication to work effectively. Whenever we talk about a mouthpiece or a face piece, um, with a nebulizer, I don't mind if my patient holds on to the nebulizer to breathe as long as they're not weak. Whenever my patient appears to be weak and I don't think that they're going to be able to hold their arm up, we put it on a face mask. Okay. Meter dose inhaler. That little orange piece right there is the actual inhaler. What you see in front of it, that big plastic piece, that is a spacer. Okay. Um, it is common practice to apply spacers onto your meter dose inhaler and have the patient inhale from the spacer. Okay. Some patients don't have spacers or they don't carry it, so they can go straight from the meter dose inhaler into their mouth. Just make sure this patient takes a deep breath and holds their breath as long as they can comfortably. Okay. I'm not going to force the patient. Oh, you got to breathe. You got to hold your breath longer. No, it's as long as they can comfortably. You just want them to take a deep breath to get, again, that aerosol medication down deep into their lungs. Okay. Uh, Leukotriene modifiers. Don't really see many of those inside EMS care, but that can help with hospitals. They might give a little bit more medications that block leukotrienes from affecting that patient's breathing rate or bronchoconstriction. Electrolytes, the one electrolyte that is very commonly affected is magnesium. Okay. In severe asthmatic patients, MAG is a drug that we will give. Typically, it's one of our last drugs. And believe it or not, it's the only drug that's required to have an IV for respiratory distress. So, how I look at this is if my patient's an asthmatic, and one of the first drugs I give that patient is Epi 1 in 1000. Okay. It's going to be an IM intramuscular injection. I do that first. Why? For severe asthma, because it's fast, right? I could get that drug on board quickly. Then I'm going to consider my albuterol Atrovent cocktail nebulized, right? So I'm always having a paramedic setting up that nebulizer once the epi has been administered. Then we can go ahead and start looking for an IV. Solumedrol. Some of you might be considering solumedrol, which we're going to be talking about here shortly. But solumedrol, uh, it takes a while for it to actually work. And I can also give it IM. It doesn't have to be IV. So just understand the only drug that has to be given IV is magnesium. But once I give all those different meds, I am going to be giving my mag sulfate. Now, look at the one thing that it says on the slide. It says can cause hypotension. Just understand, first and foremost, why are we giving mag? I'm going to give this patient 2 grams over 20 minutes. Now, why am I using it? Some of you might say, well, mag is an electrolyte, and maybe this person just needs electrolytes. Okay, that's only part of it, right? What mag does is it causes smooth muscle relaxation. It is not a smooth muscle relaxer. That's not its classification, right? Its classification is electrolyte, but it does have properties of smooth muscle relaxation, which is going to help those bronchioles open up, but it also causes vasodilation. So if your patient has uh, hypotension, be mindful. You might drop the blood pressure and expect to see facial flushing. Completely normal.
Because remember, all those blood vessels are dilating in the face, so you're going to see that patient look beet red while the magnesium is working. Not a problem. Okay. Here it is, our corticosteroid. Our corticosteroid that we typically talk about is solumedrol, methylprednisone. Now, methylprednisone or solumedrol, I said, takes forever to work. And now understand why we give it edema, aka swelling. It's not maybe the swelling that you're thinking, like, oh man, their neck is swelling or their tongue is swelling. No, that's not why we're using it, even though you could use Solumedra for that. We're typically using it in respiratory distress patients because there is airway swelling. Okay, so there's some edema that's starting to occur around the bronchioles, thus causing bronchoconstriction. So we want to reduce that. Now, the problem with Solumedrol is the amount of time in which it takes to actually work. Take up to 4 hours for that drug to work. Okay, something to consider. Not telling you don't use it. Use it, right? It's going to help the patient in the long run, but it's not something that I'm like super concerned about right here, right now. Epinephrine, my nebulizer treatment, my mag sulfate, those things take some priority on my patient. Says some adverse effects. Cushing syndrome. Cushing syndrome. That is that's too much cortisol in the body. Okay, it's Cushing syndrome. If you haven't looked at endocrine emergencies, I'm pretty sure I have a video on that. Check it out. Rapid change in blood glucose levels, blunt the immune system, which can be problematic. Some patients take corticosteroids via meter dose inhaler, and they get thrush. Okay, so their tongue gets candida, and like it gets like that white paste on their tongue. Pretty gross, if you ask me. Of course, that's the next one. Inhaled corticosteroids. It says IV corticosteroids, no apparent negative long-term effects. Methylprednisone, hydrocortisone are the IV boluses. Remember, it's 2 milligrams per kilogram, but max dose of 125 milligrams. In EMS, it's very common to hear people just say, I'm going to give 125 of Solumedrol. Vasodilators says sequesters more fluid in venous circulation and decreases preload. So if your patient has a heart issue, why would we ever give them a vasodilator? Okay, there's one patient in particular that is short of breath that requires a vasodilator. And if you guessed CHF or left-sided heart failure, you're right. Okay, but why would left-sided heart failure require vasodilators? Let's talk about it. The heart is failing. It's not working too well. Okay. Blood is starting to back up. But you want to know what happens is the same amount of blood is getting pushed around your bloodstream, right? And guess what happens with CHF? When your heart starts to fail and your brain starts to notice that, hey, we're not getting as much blood flow, your brain actually causes your pressure, blood pressure, to increase, to push more blood, right? So there's this compensating factor that's occurring inside your patient with CHF that is increasing pressure. Well, when you have an increase in blood pressure, what do you think's happening to your preload? The amount of blood that's getting to the right atrium of your heart. It's increasing, right? You have an increase in preload. But when you have an increase in preload, what kind of stress do you think that causes on your heart? That is failing and dying. It's causing problems. So, how do we reduce stress and workload on the heart? We give them nitrates. Okay. I'm not giving patients nitro to allow more blood into the heart. I'm giving nitro to reduce the preload, to reduce the stress of the heart. I hope that makes sense. Obviously, I'm also going to be giving that patient a CPAP, right, to help keep those alveoli open, to help get that fluid out, and to also help reduce preload. So I hope that helped. Right here it says morphine sulfate not likely to increase venous capacity. Morphine is an interesting drug whenever we talk CHF because even though it's not seen as common as it used to be, Morphine is actually not a bad choice for your CHF patient. Why? Because it reduces preload and it helps calm the patient down. So we're not using it as an analgesic because the patient's in pain. We're using it to help the patient relax and to reduce workload of the heart. Restoring fluid balances. Just one thing I could say about fluid balances, it's not always safe with shortness of breath. Okay. Look at this first one that it says here when it says assess the breath sounds before and after your administration of fluids. It says hydrating patients with pneumonia may spread or may cause pneumonia to spread. If you know that your patient has pneumonia, on test questions, by the way, that's usually unilateral, one-sided, adventitious lung sounds such as rhonchi, or they tell you, hey, this patient's sedentary, they're not moving around a lot. Hey, this patient's got a fever. Whatever the case is, if you're suspecting pneumonia, you giving them a lot of fluids can make the pneumonia worse. Okay. Um, if my patient has pulmonary edema and I give them fluids, I can make the pulmonary edema worse. Understand those concepts. Typically, if I'm ever giving fluids to a patient, it's because their perfusion is poor and I'm trying to improve perfusion. Diuretics. Oof. Diuretics are a great drug when used when they're supposed to be used. Okay. Now, the problem with diuretics is they've actually been removed from the paramedic scope. It's hard for me to say that. Um, I would never say that paramedics can't give diuretics. What I will say is that it's not recommended in pre-hospital settings anymore. Why? The use of something like Lasix, which is a loop diuretic, will cause dehydration, can lower blood pressures, right? And must be used on patients that suffer from left-sided heart failure. That's what it's for. It's for patients that are suffering from left-sided heart failure. But is there an imposter out there that has crackles? Yes, the imposter is called pneumonia. If your patient has pneumonia and you give them Lasix, it's a problem. Okay, that's a contraindication. You can't give it to a patient with an infection. You can't give it to a patient um, that is dehydrated, right? So be careful. There's a reason why diuretics were removed from the pre-hospital setting because too many medics were giving it to the wrong patients. All right. But what's a diuretic there for? Diuretics again get fluid out, makes your patient urinate. Okay, so it gets those kidneys working and gets your patient to get rid of excess fluids. Good medication does work, but again, has to be used on the right person. Says it will cause a potassium loss, obviously, because that's how you get rid of potassium is urination. Um, It says can lead to cardiac dysrhythmias and chronic muscle cramping. Not for patients with pneumonia or dehydration, like I just said. Higher doses required for renal failure. Um, Typically, if patients are on diuretics, it's because they have an issue potentially with their renal system, so they might already have high dose uh, diuretics. So know that stuff kind of before you start treating them. Assisting ventilations, I feel like I kind of hit this pretty good with my respiratory management lecture, but let's go ahead and take a look. It says if patient becomes fatigued, breathing may need more aggressive support. Absolutely. CPAP and BiPAP may preclude intubation. If your patient ever becomes fatigued to a point where you start to see either head bobbing or the patient starts to become altered, please take those off, especially the CPAP. Continuous positive pressure can actually kind of like take over that patient's respiratory drive and they might stop breathing on you. Take it off. Patients may require BVM. First thing it says CPAP used to treat obstructive sleep apnea. Typically, not the reason why we're using it in the pre hospital setting, and respiratory failure. Oof, that was a very tough thing to say. I don't really like how they use that, but okay, let's take a look. It says patients with obstructive sleep apnea wear CPAP unit to maintain airway while they sleep. There's a lot of different ones, obviously, that you see in that list. Typically, when somebody snores, I don't want to say it's always a precursor to sleep apnea, but it can be. Somebody who's snoring gets like excessive. It can get to a point where their tongue actually obstructs their trachea to the point where they stop breathing while they sleep, known as sleep apnea. So these patients need to be on a sleep study, and then they get prescribed a CPAP to go home with them, where this thing runs on their face while they sleep, and it helps maintain airway patency so they don't die. Pretty straightforward. Remember, all CPAP is continuous positive airway pressure, needs to have a perfect seal around the patient's face, and it forces the air into the upper airway, maintaining airway patency, and creates a positive pressure in the chest. That positive pressure maintains the alveoli to stay open to allow for gas exchange. And if there are fluids inside your patient's lungs, it can help push that fluid out. Says bag math ventilations produces positive pressure in the chest, and pressure that is too high can cause a tension pneumo, subcutaneous air, or even block venous return. Time and time again have I seen test questions talking about positive pressure ventilations decreasing cardiac output. By that, blocking venous return. Remember, creating a intrathoracic pressure by too forcefully ventilating a patient could apply pressure to the vena cava. And whenever you apply pressure to the vena cava, that can actually cause a decrease in cardiac output. Understand that. What it's showing here is like knowing that you can do a perfect seal, right? So I'm going to be honest with you, not all EMS agencies are running around with this CPAP looking machine when they're bagging somebody. Understand that if you are doing it by hand using the CE clamp is uh, still a great way to hold a seal, but not everyone's hands are the same size, so it's kind of challenging for people with smaller hands. The best way to can maintain a seal by utilizing a CE clamp is two hands. Keep two hands on that patient's face on the mask while one another person bags. Have seen test questions on that. High level positive airway pressure is known as BiPAP. The only thing that's different about BiPAP and CPAP, remember, CPAP is continuous. So it's constantly flowing air into that person's face. BiPAP, whenever the patient breathes in, it's triggered to basically shoot air at them. But then when they're breathing out, the BiPAP shuts off the air. Okay. So it like turns on to assist with the ventilation, shuts off. Turns on to assist with the ventilation, shuts off. Okay. It's not continuous pressure. Remember, continuous pressure with CPAP, the whole purpose of it is to breathe against that pressure that's blowing in their face to maintain the alveoli open. So BiPAP, it says here, more complex, more expensive, absolutely typically seen in longer term care, such as in hospitals. Auto vents. Auto vents are great small tools that all we do is set a rate in which we want it to deliver air and the volume at which we want it to set air. Some of these ventilators will actually, we could adjust PEEP, the amount of positive and expiratory pressure. We might even be able to set the FiO2, so the amount of inspired air. So there's a lot of different things that we could set depending on the ventilator type, and it frees our hands, right? So I can set a specific ventilation rate and volume and concentration of oxygen, and I don't actually have to put my hands on the BVM. Great tools. Intubating the adult patient says intubation is last option for patients with severe asthma. Uh, absolutely, man. You ventilating a patient with severe asthma can be problematic. I'm going to be honest with you. I would prefer always to just treat these patients with medications, put them on a nebulizer, coach them, try to get them to relax and get that air into their or those medications deep into their lungs mag, epinephrine. Treat these patients. Once the patient buys a tube, there's an increased chance first of causing blebs, right? Blebs are too much air inside, like because remember they have air trapped in their alveoli. Air is trapped because the bronchioles are so constricted, and now I'm forcing more air in with positive pressure via the BVM. It can cause some barotrauma, so there's a lot of issues with ventilating patients that are asthmatic. Typically, you're supposed to do like a slower breathing rate, less air, things of that sort, but it doesn't always happen, to be honest with you. So intubation is considered a last resort. Ventilate patients before cardiac arrest, obviously with intubation. Patients who are severely intoxicated or have had a stroke may have no gag reflex. Now, why is no gag reflex a problem? If the patient is unable to protect their airway, via gag reflex. That means they can't cough. If the patient vomits or the patient has maybe like excess saliva in their upper airway, they're breathing it in. They're not clearing their airway. And having an unmanaged airway like that is a problem. And us as uh, care providers have to take over the airway to protect that trachea. Aspiration is bad. Says with diabetes or overdose, an amp of D50 or naloxone uh, should be used before intubating these patients. I'm okay with you ventilating them. 100%. Okay. You walk into a house, you hear the snoring respiration, someone breathing at 5 breaths per minute. What do we do first? They have pinpoint pupils. Do we give them Narcan or do we bag them? The answer is bag them. Okay. You're going to pull out a BVM, hook it up to an oxygen source, assist ventilations while somebody's drawing up the Narcan. That's the answer on a test question. Okay. So assist ventilations, we're going to administer the medication. And as that patient starts to wake up, their respiratory rate starts to get better and better. They start to come around. We can then discontinue ventilations. It says administer it slowly, please. Administer slowly. Dextrose is kind of like a syrup. It's a pretty high concentration of glucose. And if you pop a vein or you give you excavate outside the vein, you start to push that drug, it will cause tissue necrosis. So please push it very slow. And as for the Narcan use, if you push Narcan too fast, you'll actually cause the patient to vomit, which is also not good. Be mindful, be careful. Says here now, subcutaneous beta adrenergic receptor agonist. Okay, so whenever we talk about a subcutaneous injection for a beta 2 agonist, we're talking about terbutaline. Terbutaline is a medication that is 0.25 milligrams subcutaneous. Um, and it's typically I'm using that if I don't have a nebulizer. If I'm unable to nebulize for whatever reason, if you don't know, when COVID was going on, we were not nebulizing patients in the back of the truck because we were afraid of spreading the COVID. So we were using terbutaline subcutaneous. All right. Anatomical obstruction, getting into FBAO. And we know the first and most common airway obstruction in the upper airway is the what? The tongue. Most common cause of airway obstruction. Okay. Tongue obstructions lead to death. So whenever you hear snoring respirations in a test question or even in real life, maybe in a scenario, something of that sort, just know that that's a tongue obstruction. We need to relieve the tongue obstruction. You're either going to do that by a head tilt chin lift if you're not suspecting C-spine. And if you are suspecting C-spine, you're going to perform a modified jaw thrust while holding the patient's head still in a neutral position to maintain C-spine precautions. All right, guys. So this concludes part one of respiratory emergencies. And part two, I'm going to be discussing COPD versus asthma, some CHF, airway swelling, different things like that. We're going to get a lot more into management. So check it out. See you there.